Hi everybody, welcome to Facebook Friday. I am Kate Wakelin from Neuroendocrine Cancer Australia, and those of you who join us regularly know that each week on Friday we come in live to our Facebook private discussion group to focus on a topic of the week. So that's what we're doing today, and it's lovely to have people join us, and you will be able to see that actually we've got a very special guest who's also joined us, so I'll be introducing him in just a moment. But before I do, I just want to acknowledge the traditional owners of the land that I'm broadcasting to you from, which is the land of the Wurundjeri people of the Kulin Nation. Just want to pay my respects to elders past, present and emerging. This morning I went for a very chilly walk along the Yarra River, which in the Woiwurrung language is called the Birrarung. I know that's a very significant place for the Indigenous people in my area, and I'm very grateful to be where I am, and knowing that people are joining us from all of the various corners of Australia, and so extending that acknowledgement to where you are joining us from as well. So without further ado, I would like to introduce Professor Jas Samra. Jas, I know, is known to many of you, and actually I know that he has seen plenty of people's insides who will be watching this live broadcast, so that's a bit that's an interesting thought. Jas has got some, we've already had some questions submitted by our audience. Jas is a surgeon and Jas works at Royal North Shore. But just to let you know from the get-go that all of the discussions we have today will be just general in nature. So for your own situation and for your own advice, please talk to your own treatment team. We know nets are incredibly diverse. We know bodies are incredibly diverse. And so please don't take anything that you hear today as being anything that you need to necessarily, do anything about or change, but certainly take questions to your medical team, your treatment team, and see what they say about the situation. And I can see some people are commenting and saying hello, which is excellent. I mean, it's working. So Jas, thank you so much. I so appreciate you joining us today.
Thank you very much, and I would like to thank the Neuroendocrine Cancer Australia for giving me the opportunity to talk to you. Thank you.
Fantastic. Jas, you're a little soft to me. It might be that I just need to turn my volume up, but maybe people could give a little bit of a comment if it's loud enough for them. That would be awesome. And maybe if you can just keep fairly close to your microphone so we can hear you. I just would hate to carefully craft answers to questions and then find that we're not capturing you. So I wanted to start. Jas, how long have you been working at Royal North Shore for?
18 years.
Okay.
Long time.
Yeah.
I was fortunate enough to be a registrar at North Shore and then as a fellow, but as a consultant, I've been working there for 18 years. But I've been at North Shore for now 25 years.
Wow. Okay. So you know the place well.
At the back of my hand.
I'm wondering, Jas, if you could just share with us, firstly, before we get into the really nitty-gritty questions about debulking and transplants and surgery in general, what drew you to being a surgeon?
Well, I was going to be a mathematician, but I didn't get to the right university and the right course because in England, you have to have a French O-level if you want to go and do mathematics in Cambridge. And I didn't have a French O-level. So my default choice was medicine. And I really didn't know whether I really wanted to do medicine because this is in the good old days when you were 18 and you ended up doing a course and you really didn't know where you were going. Okay? And it was really when I became an intern, a houseman, I had a panic attack thinking, hang on, this is all about my life, what I'm going to do. And had a little bit of a thought, and I thought I'll do emergency for a short while and see what I like, and then take it on from there. And during that period, when I was a junior doctor, you rotate around different specialities. And often it is your mentors, people who you admire, you tend to get into that specialty. And I just happened to be mentored by some great surgeons, people like Sir Miles Irving, who was a very famous English surgeon, who made a sort of a great impression on I'm sure, on vast majority of his trainees. And that's what sort of led me down the surgical path.
Wow. And so did you commence surgical training fairly smoothly from your initial medical training then?
Yes, I did. Yeah.
Yeah. So how long have you, without giving your age away, how long have you been a surgeon?
Uh, Look, it depends on what you classify as a surgeon.
Mm.
As a surgeon, as a consultant surgeon, where you are independent surgeon, I've been since 2003. Okay, but the surgical training can vary. So some of us would do internship and then residency and then 4 year or 5 year program in Australia, okay, and then become surgeons. Others will take a rather long-winded route depending on what you want to specialize in. So you might do intern, you might do a residency, and then spend a couple of years training in other things, trying to find your feet, as it happened in my case. And then you do your surgical training, and then if you're keen and interested in research, you might do a 1 year as a master's or 2 years as an MD. Or if you're really keen, you might spend 3 years. And I ended up doing 3 years, a PhD in research, and then went back to further surgical training. And then often nowadays, you end up doing 2 years as a fellow before you get appointed. So it's a 10-year postgraduate training program roughly.
So it's a long path between being that fresh young 18-year-old who didn't do French and then found yourself in medicine to becoming the surgeon that you are today. So look, that's really interesting. I always find it fascinating to hear what's drawn people to these sorts of careers because, you know, we know you make such a tremendous impact on people's lives. So
it's a very rewarding journey. So it's not the end of the journey, it's how you take that journey. Okay, which is really equally important for any training. Okay, because often people just want to become specialists at the end of the day. And I think most of the people who are actually in the training actually enjoy that training and camaraderie. And it's a wonderful learning process.
So I wanted to ask you, I know we're a little bit late starting today because you were talking with a patient about an upcoming procedure. And I wondered if you could tell us what sort of things play into the decision-making process when someone might be considered for surgery. So both within the medical team, but also I think it would be really useful to get your insights about the sorts of things that you're talking about with the patient in order to evaluate that and weigh up that decision. Because it's a big, it's usually when we're talking surgery for neuroendocrine tumours, they're big operations often.
They're big up and they're very complex because these patients, the behavior of the tumor um, is very variable. Okay, and sometimes the patients are young, sometimes they can be old. So you have to look at, and these tumors can go on for many years. So um, even with the metastatic stage where they've gone elsewhere. So you have to work as a team. So as a surgeon, I can give my surgical opinion. I have some insight into the medical treatment, but that's not the area of my expertise. So I can technically talk to them about the surgical issues and see where we are going. But really, the decision, the crux of the matter where it gets sorted out is at the multidisciplinary team, where we present the patient's data. Okay, I know the patient, what they are like, physically, what they can tolerate, what they can't tolerate. And then we discuss freely among the surgeons, the gastroenterologists, the interventional radiologists who tell us exactly the extent of the disease, the nuclear physicians who can tell us the aggressiveness of a tumor depending on the PET scan, whether they are positive on an FDG or a gallium dotatate PET, and interventional radiologists who may want to treat them with a lutate therapy, and the oncologists who may say, well, hang on, this is a bit more aggressive disease, they may need a chemotherapy or a SIRT. So, and it's really, I only am one part of that, okay, and there are multiple parts of it, and you really want to give your colleagues an equal say in the management, and then sit down and have a really frank discussion as to for that particular patient, which is the best pathway. And really important in that committee to um, go through all the permutation combinations, and preferably for the patient to see some of the players who are going to be looking after you, and so they can actually then work out, have questions and answers answered. So there is always a bit of a latitude as to there may well be 4 options, but 2 are better options and 2 are not so good options, as to which of those 2 options you're going to take. If there's a surgeon, he's always going to say surgery. If it's an oncologist, he's going to always say, oh, it's medical therapy. But you want to talk to both of them, and really the patient should decide. Our job, I think, as physicians nowadays and surgeons, is to educate the patient and for the patients to decide what's the best option. And I think that's really, really important in these complex decision-making processes.
And I think what you're saying really highlights the importance of working with a multidisciplinary team. So like you said, if you see a surgeon, they will think of surgical options. And if you see an oncologist, they'll think of chemotherapy type drug options. And so it's really, I think, it's been demonstrated statistically the value in getting the whole team's collective consensus. I wondered, I was at a support group this week, Jas, where one of the people had their case discussed at the multidisciplinary team, and she saw her doctor afterwards, and the doctor said the team has decided this is the best course of treatment. She was feeling a little curious because she was thinking, gosh, were there other options that I could have chosen from? And I wondered if someone has, if a multidisciplinary team has come to a consensus, a firm conclusion, will that be, how likely is it that it will be that one option is strongly suggested by the multidisciplinary team?
Look, I think you asked a very relevant question. I think that's why I think the patients have to be empowered. They should have the right to make the decision. Okay, and I think just by seeing one person, and they should be in a position to say, well, actually, I want to have a chat with the oncologist, and they should have a chat with the oncologist. And if they're unhappy, you can have 2 of the nicest people. You can have a really nice patient and a really nice surgeon, but they may not be on the same wavelength. And you have to trust them with your life, and the surgeon and whoever your doctor is have to repay that trust. So the first thing in that trust is that patients should have a choice. You can tell the patients what you think, okay, and what your MDT thinks, but it has to be the patient's final choice. And if the patient doesn't like it, I always say to the patient, look, this is the opinion that we think is probably the best suited, but it's not, absolute thing, okay? And if there is a doubt, please get a second opinion. In life, you're going to get a one bite of the cherry. It's a fairly long journey, so you want to be taking the right journey, and you want to have a confidence in that system. Okay? So there's no harm ever in getting a second opinion.
So if someone asked me that this morning, a newly diagnosed person who said, well, wouldn't my doctor who I'm currently seeing feel offended if I asked for a second opinion?
Heaven forbid, no. I think we would be delighted for people to get a second opinion, okay? Because I think it puts the patient's mind at ease that everybody's doing the right thing, and it puts the surgeon's mind, because sometimes things won't go right. You won't get things will go wrong. There are complications of every treatment. Then at least the patient is happy that this was not something, the path that was taken with the right intention, the right information. And unfortunately, sometimes, we get bumps in the road, okay? And this is just a bump, and they would have a trust in the system. If they get a complication when they had that uncertainty, that is likely to play a much more significant part in their well-being, and in the fact that, they may feel that maybe they took the wrong decision and was the wrong road. So I think it's really important to have that sorted out to start with.
I think it's really valuable for you to reassure people that this, seeking a second opinion and asking the questions is actually really fine. It's okay to ask the questions. It's okay to seek a second opinion. And it's really, I think you talk about the importance of feeling firm in the decision that you're all coming to. I wondered, someone has just said, actually, and people are putting some comments in the notes, which is excellent. I can see Simone Layden is watching, and we're all very grateful to you for your time. One person has said, and maybe this is a very big question, so I think it is, but let's go there. What pathology tools do you use to decide that surgery will be, the recommended option? And I think that's a big question, but and I know it's in the context of long-term tumor management. So yeah, what pathology tools do you specifically look at?
So surgery is a tool that can be used. It's a limited strike. Okay, so if you got a disease which is limited in a certain place, okay, for example, if it's a localized disease only at one spot, then surgery is a reasonable option. But the fear always is there a microscopic, a small cell sitting there? Okay, because what determines your survival is not necessarily what gets taken out, it is what's left behind. Now, theoretically, you can say, well, hang on, if even only one or two cells are left behind, they're going to come back. But what happens in reality is if you have a tumor which is gone, let's say from your pancreas into your liver, and you have a one big spot in your liver and you have a one big spot in your pancreas, yes, there may well be a small disease. But if the tumor itself, which is metastasized, and the primary tumor, which is in the pancreas, they would be shedding cells. Now, most of those cells will be destroyed by your body, okay? But there will be some that will get taken up by other tissues, and they will come back. Okay? So just because you don't see them does not mean they are not there. Okay, and so the question is, if you don't see them and you think on a probability basis wise you can get all that out, then it is probably not unreasonable to take them out. But somewhere down the line, you need an alternative strategy. How are you going to deal with those microscopic disease that you can't see? And sometimes you go in there and you find there's a little bit of a disease elsewhere. And what do you do? What the right thing to do is, okay? So others might say, so that's one side. The others might say, hang on, you've got a high chance of having a disease elsewhere. Why don't we give you an alternative treatment like a chemotherapy or a lutein therapy, and then take it out and then see what's happened to it. Okay? And if the disease that we've taken out is almost dead, then we know if there's cells floating around, then there's a high likelihood they would be killed. So these are the arguments. They are sort of theoretical arguments that go through the committee's heads, when the tumor board or the MDT committee's head. And that's why it's really important to know exactly what you're trying to do. You're trying to model or predict the behavior of a cancer. And so there's a lot of guesswork that goes in. Now, the thing with the neuroendocrine tumors is the wide variability. So, for example, there is something called Ki-67, which is a marker of aggressiveness of these tumors. So you can have a Ki-67 of 1% or a 0.5%, which you know is going to be very indolent disease. And on the other extreme, you can have a Ki-67 of a 90%. Now, if you've got a Ki-67 of 90%, that disease, it's a very aggressive disease in that case. It is not going to be cured surgically. And so often, surgically, even though some people say, well, you're quite an aggressive surgeon, okay, from pushing the barriers, I would say when you know the biology is that aggressive, you are not going to do it. There's an old saying in the surgical circle. Normally the biology is the king, the selection is the queen. So if you have a very aggressive tumor, as a surgeon, you are not going to win. The selection means that if the patient is elderly, they are not going to be able to tolerate surgery. It doesn't matter how good a surgeon you are, you're not going to win that. Whereas a younger person, yes, he can probably recover pretty well. If they get a complication, they will recover well. So there's this technical surgeon, we are really at a third base. So often as a surgeon, there are other important things. And I think you really need to take that in your step when you make these decisions as to what is it that I'm trying to achieve. And the best way of looking at it, I find, as my decision making, is if I was in that person's shoes, and you can never really be in that person's shoes, but you try to put yourself in that person's shoes, what would I want knowing what I know? And you would ask the same questions from your oncologist at the MDT. And that's why the MDTs, we don't have patients at the MDT, because those discussions can get quite heated because there is no right answer sometimes. And I think the patients need to appreciate that it's a sort of, maybe 70-30, 60-40, and sometimes it's just 50-50. Okay? And very rarely it is 100% and 0%. Okay? And that's what, and I think we need to inform patients that that's why there is a complexity in this decision making. So yes, we rely on Chi-67, we rely on a PET scan, we rely on there are different types of PET, for example, FDG PET, which tells us a more aggressive disease, gallium dotatate scan, where it is. For example, if you have a single lesion on the surface of the liver, okay, you can take it out very easily. Where it is deep in the liver, you will have to do a lot of collateral damage to get to it. So it may well be better in that case to have alternative strategy, i.e. microwave ablation, where you can stick a little needle into it to cook that disease. So it really is case per case, what you're trying to do, what you're trying to achieve at the end of the day, to keep this cell tumor volume low, and to try, because the other thing is that you can be very aggressive as a surgeon, or with your chemotherapy, or with your nucleotide treatment, and actually impair the quality of life for the patient without actually giving them a significant survival benefit. So you have to take the quality of life into the equation as well. So that's why I think these are really, really hard decisions. And that's why the patient need to be informed, needs long discussion, and maybe have 2 or 3 consultations with the patient. And that's why it's really good for the patient to see maybe get a second opinion.
So thank you. I know that was a complicated question to ask. You talked, Jas, about when there is a single tumour and the person is, young enough and healthy enough that they should be okay to have the operation, then it seems like it's a fairly clear-cut decision. I wondered if we could talk a little about when there is metastatic disease and the concept. There's 2 things that I'm curious about hearing your thoughts on. The first one is debulking. So when we have a person, and it's often when there's liver tumours that have grown from the small bowel or from the pancreas, and again, the decision-making process about when debulking can be offered and what's the benefit of removing liver disease particularly. So that was the first question. The second question is when there's metastases, so when the tumour is spread from where it started and it's gone somewhere else, is there ever an advantage in taking out that primary tumour? And I'm talking specifically about the small bowel, which I know is a question that lots of surgeons argue about. So I'm interested in your thoughts about those 2 scenarios, if that's okay.
I think that's really interesting, those 2 questions, and probably the ones which are the most difficult to answer, but I will try my very best. Okay, let me just digress a little bit. Okay, when you have a single small tumor, okay, surgically it should come out. That's not always true. If you have a very small tumor in your pancreas, let's say an 8 millimeter neuroendocrine tumor, does it need to come out? The answer is no, it doesn't necessarily need to come out. You can keep an eye on it, because the risk of surgery may be greater for the time being than just keeping an eye on. Now, if you keep an eye on it, and for example, it depends on the age of the patient. So if you've got a 60-year-old patient who's got an 8 millimeter tumor, or a 70-year-old 8 millimeter tumor, it may well be not unreasonable to do a scan in 6 months and then in 18 months, or keep an eye on it. And if it's not growing, it's staying as it is, and on a gallium dotatate, it's got a low, is positive, and a Chi-67 is 1%, you may not need actually to do a surgery. You may want to keep it. Okay, that was so single tumors necessarily don't need surgery all the time. Okay, so that was there's limits to where one would operate. But the metastatic is, on the other hand, it depends on what type of metastasis you have. So if you've got a multifocal disease and you've got a multi-system disease, not only...
So multifocal means in lots of different spots.
Yeah. So if you have, let's say, it's going into your bones, okay, and then doing a liver surgery is not going to make much of a difference. So on the other hand, if you have a disease just confined to your pancreas and your liver, or small bowel or your liver, then it becomes very much more a sort of a manageable thing, and in a way a bit more complex thing. Now, if you have only 1 or 2 big mets, then the surgery may well be a reasonable thing up front. Okay, and I'll come to that. Why theoretically? Because if you give them a lutate, the lutate is given total body dose. Okay, so you would give an X amount. Now that's going to go into equally into all the liver lesions, to the pancreas lesions. So theoretically, you can take those out, and then the microscopic disease that's left, you're going to give them a lutate. So it's got a much better chance of hitting that disease, because otherwise the tumor that's going to come out, the lutate is binding to that, and you're wasting that lutate.
Ah, okay. I haven't heard this being explained in this way, but it makes sense to me. Thanks, Jas.
So it's a theoretical argument, okay? On the other hand, you can give them a lutate, see what the response is, because lutate can be given repeatedly. And if the response is good, and if they've got a limited disease, take it out. But then you may have to give a lutate for the second time, because there might well be you haven't really hit all the disease that's there. So we really don't have a firm data. So there are two schools of thought. There is the American school of thought, which is more aggressive in taking it out for that reason. Why? Because they don't want to waste their lutate, because that's the fixed dose. So the lutate dose doesn't necessarily depend on the amount of disease you have. It's like a fixed dose. So you don't want to be wasting it on a disease that you're going to take it out. Okay? So that's why the Americans sort of go down that pathway more often. But the advantage of it is that how well is the lutate binding, because the binding of the lutate depends on something called the SSATR receptors, because these are found on neuroendocrine tumors. So if you have lots of receptors, it will bind. If you have not so many, it probably wouldn't bind so well. Okay? And especially if it becomes an FDG avid. So there may well be metastases which don't take up any of the lutate. So, and they are FDG positive. So they're going to behave more aggressively. So you can have a mixture of a disease, very aggressive disease. And that mixture of a disease, then you may want to strike that disease out up front, because you know that's the aggressive disease. That is what's going to determine your survival. So you might want to take out the FDG disease, but not
we talked last week about low grade and high grade tumors, and I'm not sure if anyone was watching the video last week, but we talked about people where we get a bit of a mixture, and I guess you're talking about if there are tumors that are glowing on an FDG scan, that means they're faster growing, and so that might be they might be good ones to take out, because you can't treat them with the lutate or the PRRT, but they're the ones that will be behaving the most aggressive. Is that some summary?
Yeah, absolutely, that's true. So if you only got one of those, you might want to say, look, this is the one which is going to be the important predictor of survival. We'll take it out. On the other hand, if you've got lots of those, okay, and then you might say, well, surgery is not going to work because they've got a lot of aggressive disease, especially if it's outside the liver. You might want to go down the path of chemotherapy. And if there is chemotherapy works really well, and then you may have one or two foci which haven't responded even to the chemotherapy, because there will be a variability, you might want to take them out after the chemotherapy. So it depends on the disease distribution and what you're trying to do at the end of the day. Now,
yeah, so it sounds like the plan emerges as you go too, that you have, sometimes you do some chemotherapy and see what happens, and then that might change the recommendation.
Absolutely.
Yeah.
So the second school of thought, which is to give everybody a lutate, especially if they were positive on a gallium dotatate, the advantage is then when you take it out, you can tell how well has the lutate worked. Okay? And they didn't have to undergo a surgery, which is a morbid process. And you can see that's a pretty reasonable thing to do. Okay? For example, if the patient is a bit more frail and you are having to do a big liver resection, that would have a morbidity. Okay? That would certainly, take them time to recover from it. Okay? And they may not be able to have an alternative treatment in the meantime, and especially if their disease marches on. So you don't want to block certain options for those patients. And that's why you need to have a sensible approach. So I think both schools of thought are right. It really depends on what the patient feels and what the team feels is appropriate. And that's why there is no black and white, just shades of gray as far as that task is concerned.
So the question about taking out primary tumours, and I think that was great that you mentioned about the small pancreatic tumours, because people often ring me and they're panicking because they've got an 8mm pancreatic tumour that is low grade, and they're worried because it's not being taken out. So I think that's really useful for you to mention that. What about small bowel tumours?
Small bowel tumors are are actually probably more difficult from that point of view, because what they do is they do two things. First of all, a lot of these are carcinoids, and they would produce a substance which causes a stricturing. So they would often end up with a small bowel obstruction. And then they have to be operated in the middle of the night because they present with a bowel obstruction. And you may not have the right team. And if you end up in a local hospital, they may not have the expertise to look after you. So you end up having an emergency surgery in the middle of the night by the surgeons who are not necessarily experienced in looking after that. So therefore, a lot of us feel that if you've got a small bowel primary, provided you are fit and well and you have a relatively low grade disease, okay, and even though it's not treatable surgically, you may want to take the primary out. So in most cases, our MDT will recommend the primary to be removed because it's going to land you in trouble. The second thing they can do is bleeding. They can bleed from sometimes, but it's obstruction is the most common cause.
Okay. So I went to a support group this week, and one of the people at the support groups mentioned that she's getting quite a lot of symptoms of bowel obstruction. So she's getting pain, she's getting material not passing through. She's already been in hospital a few times with other bowel obstructions. She didn't want to tell her doctor about the symptoms because she was worried what they might say, but is going on lots of trips to remote areas. I encouraged her to talk to her doctor about her symptoms. I imagine that you would be agreeing on that basis.
Look, I absolutely agree. I mean, I think that's why it's really important to have the confidence of the patient, and they can talk to you about everything and everything, because you have to be almost like in their shoes. Okay, they have to feel that they are in control and they can discuss anything with you as far as surgery is concerned, and even sometimes the end of life decisions to have a treatment. And as a surgeon, I think it's really important not to be judgmental about it, okay, and to accept what they want. Now, if somebody is doing, in most cases, it's a give and take. Occasionally, a patient will say, so if a person comes to me and they're getting symptoms of a small bowel obstruction, and I say, well, in my mind, I'm pretty clear cut. I would say to them, look, I would very, very strongly consider having a surgery because you don't want to get into trouble. And if they say, no, I don't want to have a surgery, and I would say, look, I am really, really concerned. And I think this is where I think you are going to do harm to yourself if you persist with this. And I would advise you, please get a second opinion. I would feel comfortable. And then at least then if you get a second opinion, the second opinion says, no, that's fine. Okay. Then I would feel comfortable. Now, if the second opinion says that it's dangerous for you to keep on going and you need to have a surgery, then I think really the patient has been explained enough. And then if they still want to choose that pathway, that's fine. Okay. But at least then they know exactly what they're dealing with.
So it's informed consent, perhaps not to proceed, as well as informed consent to proceed with an operation. Thank you. That's useful. I hope she's watching. Another question, maybe hopefully a little bit more simple, because I've asked you some complicated ones. Does liver grow back or heal itself after surgery?
Absolutely. Okay, liver is one of those organs which has an enormous regenerative capacity. Okay? A healthy liver. So, for example, if you're not cirrhotic, okay, your liver should grow back fairly quickly, and it grows back. And the size of the liver depends on your total body surface area. There are some formulas. So it will grow back within about 2 weeks. Now, it may not necessarily have the full function. It might take another couple of weeks, but generally it would grow back. Not necessarily the same shape, but the same size. Right. So you have only a right liver, which has a right-sided blood supply and a left-sided blood supply. So if you take the right side out, the left side will increase in size to the original size, but it still only has one left side supply. So you can't keep on taking it out and out and out, because normally you will, somewhere down the line, you can damage the inputs to the liver. You have to have an input and output, which has to be healthy. So you can have multiple operations on the liver, but as long as you leave nice and healthy enough liver behind, and you need only about 30% of nice healthy liver to be left behind for it to regenerate back to full volume.
But then it sounds like the location of the tumors are also really important. So if you have to do a lot of cutting to get to tumours that can play into that decision as well. Is that what I'm hearing?
Yeah, it's a collateral damage that you can do.
Yeah. Yeah. Okay. Thank you. That's a really great to have that answered. And I knew it grew back, but I didn't know it was within a couple of weeks. So that's extraordinary. What a clever organ we have inside ourselves. The next question I had was around, and this was someone who put the question in last week sometime or the week before. And they said, does PRRT or SIRT, which is the radioactive little spheres that can be put into the liver, do having those procedures make surgery more difficult?
Not always. No, not always. So the thing with the PRT or a lutate is that we definitely know that in a large number of cases it does work. Okay? And there is a survival advantage. There's no doubt about that. But the thorny issue is what will happen is in a number of cases we see you give somebody a lutate, and then when you do a rescan them with a gallium dotatate, the scan becomes negative. Okay, you don't see any disease. Now the question is, has lutate killed all the disease, or has it become it stopped giving a signal? Because in a number of these cases, then suddenly you start seeing the tumor coming back again there. So lutate, while it does work, we do know, but it doesn't always destroy all the tumor that's there, and that's why it comes back. And in some cases, it may just be turning the signal off because you can pick up the signal, okay, but not necessarily kill all the cells. So these are the issues that we have at the moment, and there is active studies being done because to really study that phenomena, what you really need to do is to do a biopsy of that tumor, look at how many cells are alive, give a lutate, and then re-biopsy of the liver. And of course, that has some morbidity in doing a biopsy of the liver repeatedly. But that is likely, and then keep an eye on it, repeat the scan, see what happens, do the gallium dotatate scan again. And if it comes back live, do the biopsy to see what's happening. So you have a time series of seeing whether the turning off the signal of the lutate signal and a gallium dotatate, thinking that it's working because there is no signal there, and actually seeing the biology and the histopathology, looking at the tumor itself under the slide, saying whether it's alive, because if it's alive, it's going to come back. And these are sort of actively being pursued, those topics, and we don't have the answer yet. This is a relatively new field, so we need several years to get the data on these because for example, Chi-67 might be variable. Some of these might be positive for the FDG as well as gallium dotatate. But that's where the research is being done. And that's why we need to be gathering data on every patient. So that's why we do not like patients, because these are relatively rare tumors, but we do not like these patients to be operated in a small center where the sample just gets wasted. Nobody studies it, because we want to make sure the next set of that patients that come in, we have as much information as possible. And that's really important for us.
Beg your pardon, sorry.
So I think we have to gather data. So if all the patients who are listening to this program and watching it, I really would encourage them to participate in research so we can provide much better care for the next generation of patients.
Okay, well, thank you. That's useful. And so the radiation from PRRT, does that change the texture of the liver to operate on?
So the beauty of so people worry about that, but that radiation only goes very locally. So it doesn't go all the way into the liver. So locally it might make it, so if you're coming close to the tumor, yes, it could alter the structure of the liver, make it more fibrotic. But generally, if you're away from that, which the idea of the surgery is to just be a little bit off it, so you're not actually going to get a positive margin. In some cases, it would, especially if they've had a repeated lutate. But in a majority of the cases, it's yes, it's a little bit tougher, but it's not. Okay. There's no reason for not to give them a PRT.
Okay. I have a big question, but I'm going to sneak in with hopefully a simple one, maybe, before I ask the big one, because it's something that I am curious about. I talk to a lot of people all around Australia on the Net Nurse line, and some people are advised to have their gallbladder removed before they start somatostatin analog therapy, which is the monthly butt jabs for those watching at home. And we know that those medications can induce gallstones. What's your approach with that?
So my approach is that if they have had absolutely no symptoms, they've had no gallbladder problems, and they start their somatostatin, I say, look, start it, and if you get into trouble, we can always deal with it. Okay. Now, the second group of patients, they need to have a small bowel surgery or a pancreatic surgery, and they have a gallbladder. Now, it depends on how much surgery you do. So, for example, if you are operating on a patient and they have very extensive disease, then you should really take that gallbladder out when you're in there, even though they may not have any symptoms from the gallbladder at that point. Because if they're going to go on to long-acting somatostatin, they will definitely get gallstones. So upfront, generally, I wouldn't encourage them to have their gallbladder out, okay? Because it's not a question of stopping their chemotherapy and it's going to impact their survival in a long way, because the gallbladder operation, in majority of these cases, it can be done a keyhole, okay, which is you come in on the day of surgery, you go home the following day. Yes, it might take you out of circulation for about 2 weeks, okay, but I don't think, in the scale of things, it is something that I wouldn't advise patients upfront. Now, on the other hand, if they got gallstone, they're getting some symptoms of gallstone, biliary pain, and they are going to go on to it, then they probably should have it out upfront, because then they are going to be a sitting duck to get into trouble.
Thank you. That's useful to get your perspective on that. Can I just clarify then, and I could have misunderstood you, but does having lots of tumour in your liver mean that you're more likely to get gallstones?
No.
No, okay. I've misunderstood.
If you're having surgery done at that time, very complex surgery, you don't want to leave the gallbladder behind, because if you have to come back and do it, the chances you can do it keyhole is very low, and then you're going to need an open operation.
Because of all of the big surgery. Okay.
Then a keyhole surgery.
Okay, so if you're already in there having a big operation on the liver, they might decide to take the gallbladder out because that will be much more simple in that operation than going back. Got you. Thank you for, I'm glad I clarified, because I wanted to understand, and I'm sure if I'm confused, then there'll be people who are listening who might also be. So the big question, which I promised to ask you, and I know that we are limited in time, so we may not come to a conclusion, but people were wondering about, and this question I think always comes up when we're talking about surgery, is why aren't we seeing people having liver transplants in Australia? And the comparison is often made to in the USA, where I believe there are liver transplants being done for people with NETs. I would love to hear your comment.
Look, so we have, first of all, liver transplants are uncommon in neuroendocrine tumors, even in the US. They're not that commonly done, and even in Europe. There have been some patients, some well-known patients who had a liver transplant. I think the Archbishop of Greece was one of them, I think, or I'm not absolutely sure. Please don't quote me on that. But I was told that it was sort of really quite well-known, a couple of other well-known people who had their liver transplants done. And the outcomes have been acceptable in those cases. But generally, the disease does relapse back. So, for example, transplant for small bowel is not the same. A tumor that's arisen from a small bowel is not the same as something that's arisen from the pancreas. And a neuroendocrine tumor that's a carcinoid might behave differently from a pancreatic neuroendocrine tumor.
So when you say carcinoid, you're talking about originating from the small bowel?
That's right. And so there's so much variability. For example, if somebody's got a lung carcinoid and that's gone into the liver, and you want to do a transplant, that might have a different outcome from then a small bowel carcinoid or a rectal carcinoid. And there was a paper published in the Annals of Surgery. I think it was a Belgian paper, which showed that there was a lot of variability in survival. Now that paper is about 7 years old, and they looked at liver transplant from various types of neuroendocrine tumors, and they showed there was a fairly large variability depending on where it came from. And the survivals weren't that really great. There's quite a large number of patients were still dying. Okay? But it was still felt to be there was some survival advantage. Okay? So then you have to take into equation how many donor livers are there. Okay? So in Australia, I think on my last reading was that there were 6 transplants, and they unfortunately all did very badly. Now, I'm not too sure whether they had a very advanced disease. And so if you've got a limited disease, it may be an overkill to do a transplant. If it's very advanced, then the likelihood of them having a microscopic disease elsewhere might be quite high. So you want to make sure they got exactly the same disease. So you don't want to transplant them too early, you don't want to transplant them too late. And the question is, we really don't have a handle at that, okay? And we are somewhat prejudiced by our experience of those 6 transplants that have been done in Australia, all 6 of them having a bad outcome. Maybe we waited too long and did them too late. Okay? I don't do transplant surgery, but that could well be explained by that. And if we did it too early, then we might be overdoing the transplant. And as it's a relatively scarce resource, we don't encourage them. We won't say it shouldn't be done. We think it needs to be looked into it in a great deal of detail. And at the moment, there are very few patients who would really warrant going down that pathway. I think we talk a lot more about it than actually its exact role. Its exact role is very small, I think, probably, okay? And it's controversial. So I don't think we should be rushing into advising, because then the patients get a wrong idea. I've got a couple of myths. Maybe I should be having a liver transplant. That's not the answer, because even the transplant is fairly complicated, and their quality of life will deteriorate. And it's only going to deal with their liver. It's not going to deal with their bony mets, which there's going to be a high likelihood or tumor elsewhere. And so therefore, it makes life very difficult to go down the pathway of advising people to have a transplant. And as a collective of the Australian sort of ANZ-HPBA, which is the branch of a surgery which looks after the livers and the pancreases, as a collective group, our consensus of opinion was that it is such a low down on a priority, and the indication for that is so small that it's probably a topic that we should not be going down the pathway. We should probably discuss it with very small number of patients, but it's not something we would routinely go down.
Okay. Thank you. It's useful to have your perspective on that, Jas. I wondered, people often say, they talk about the anti-rejection drugs used in liver transplants, and that there's a concern also that might inhibit the body's ability to manage tumours elsewhere.
Absolutely, absolutely. So if you're suppressing their immune system, it will have some degree of impact on, because you're trying to down-regulate your surveillance T cells. The T cells they're like the bodyguards. They go around destroying altered cells, altered material. And so when you do a transplant, you want to bring their population under control a little bit and make sure they don't fight with your newly acquired liver or newly acquired organ. So now if you down-regulate their population, theoretically, if you've got a metastasis which is altered, and they're not going to be detecting that and getting rid of it. So there is that risk, definitely.
Okay, well, thank you so much. I really do appreciate your patience in sitting through all of these tricky questions. I think this is the last chance call for anyone else who's got questions in the comments. Lots of people are saying thank you, and someone's just said that's really interesting about having second biopsies and PRRT and that research, and so there's a lot of interest in the comments. So everyone's very grateful to you, Jas. So we're just going to give people just a 1 moment longer to finish up any final questions. Maybe while I'm just giving people that chance, I'm just going to do a tiny bit of housekeeping and remind everybody watching in our Facebook private discussion group that we've got an online Zoom meeting this afternoon. So if you had that in your diary, that starts at 2:30 p.m. Melbourne and Sydney and Queensland time and Tasmania. And if you're in the West, then it's slightly different. And also just to let you know that next week is Palliative Care Week. And we're very pleased that we've got an expert joining us, excuse me, Dr. Sonia Fullerton, who is a palliative care physician from Peter Mac down in Melbourne, and she'll be joining us for Facebook Friday that day. So I'm asking you to think in advance of your tricky questions about palliative care and putting them in the event listing, which is in there. So we'll look forward to that next week. And there's just lots of people saying, I'm going to watch this one again, and thank you so much for sharing your medical insight. So let's wrap it up there, and you might have a chance to I know you've just come out from seeing a patient. I imagine you've got more in the waiting room. So we're so grateful. Thank you so much for your time today, Jas.
Could I just say a last word?
Sure.
I think if we are in the treatment wise, we are in this infancy. We are learning as surgeons, as physicians, as well as our patients. So I think it's the learning process needs to continue to be going in the right direction. Okay? So what we say in 2021 may not be true in 2022, and certainly won't be true in 2025. So I'm hoping that there are going to be probably a lot of advances in the management of the neuroendocrine tumors, and what's the right thing for the right patient. And there's so much variability. I think we will get better at it. I'm absolutely sure of that.
That's a really lovely, encouraging note to end on. So thank you so much. I'll see everyone else next week. And thanks once again for your time, Jas.
Thank you, Kate. Thank you very much.
Thank you. I'm just going to press the end button if I can find it. Here we are.
Goodbye.